All right, we're going to move right along into a next session which deals with endovascular treatments, so going beyond the coronary arteries into the peripheral world, and we have some excellent speakers lined up for you. I want to introduce an esteemed faculty this morning, Dr. Nicolas Shammas. He is president of Midwest Cardiovascular Research Foundation in Davenport, Iowa, a busy interventional cardiologist who actually now spends a significant amount of time doing peripheral and endovascular work. He's contributing a lot to the data in this area and the expertise. And so he will give us a fine lecture this morning. And his topic is actually going to address something that is beginning to frustrate us as we had before in coronary interventions. He'll be talking about treatment strategies for peripheral in-stent restenosis. Dr. Shammas.
Well, thank you very much. Let me start by thanking the meeting organizers for inviting me. I'm quite honored. Manos and Subhash has been good friends for a long time. I can tell you these guys are the most passionate people on the planet. Their integrity, their prolific contribution to cardiovascular medicine has been tremendous. I am really amazed. I don't think I opened a journal, not a single time, without their names flashing right in front of me. I have to say they have done a tremendous job in advancing the field. I'm really proud to be associated with your team. So thank you for inviting me. It is a frustrating topic, no question about it. Treatment strategies for peripheral in-stent restenosis. We know very well if you do peripheral vascular intervention, it is almost like a recycling thing. These patients get out of your door and they'll come right back. It really has been a frustrating field for us for many years. A lot of our research has focused on finding ways to treat those patients. And I'm going to share with you some of the data, and I can tell you most of it is going to be frustrating. I don't think we have a solution to the problem at this point in time. Let me start by, we need the slides up. So let me, I can show you my disclosure, which you don't see, but I'm heavily conflicted with every pharmaceutical and device company on the planet, but I keep myself away from the conflict by having no equities or bonds or any form of anything, financially with those companies. But I can tell you, I do receive a lot of research and educational grants. That's what keeps our foundation going. Again, what we're going to try to achieve today is to define the problem of in-stent restenosis. Let me tell you how big this problem is. Look at procedural strategies in treating the FP or the femoral popliteal ISR or in-stent restenosis. We want to look at various options in addressing this problem and see if we can do anything, from a long-term standpoint for those patients. Again, it's not a secret to anybody. We use stents a lot when it comes to the femoral popliteal segment. In fact, our use in the U.S. currently is between 50 to 55%. If you look at plain old balloon angioplasty, is about 20 to 25%. And if you look at atherectomy, whether by itself or along with stenting, is about 25% of the time. Well, this is a very busy slide. It's an aggregate of a lot of the stent trial, but it illustrates the problem that we see, following stenting, what would occur. If you look at patency at 1 year, 2 years, and 3 years, there's clearly two predictors, major predictors of problems, of loss of patency. One is the duration of follow-up. The longer you follow those patients, the more likely you're going to find out that restenosis is occurring, patency is lost. At the same time, the longer the lesion that you treat, the higher the likelihood of loss of patency. Let me give you an example. If you look at short lesions, less than 10 centimeter, and if you look at 1 year patency, it looks about 90%. But then at 3 years, you look at it, it's about 60%. And that's with short lesions. When you look at the long lesions, and you look at patency, and that's with the COBRA trial, that Dr. Banerjee did here along with his team, looking at adjunctive cryoplasty that clearly showed reduction in restenosis after stenting. If you use that as an adjunctive treatment, still, patency is about 70%, but it goes all the way down into 25%, on follow-up. So this is a real problem with stenting. And then that translates obviously in target lesion revascularization. If you look at long lesions, which is over, typically 10 centimeter, you find that stents start to lose advantage compared to balloon angioplasty. The advantage primarily is present in the shorter lesions, and we see that in several randomized trials. But again, longer lesions, which is about 80% of what I see in my own practice, you have a loss of advantage to stenting. And then when you look at the mechanisms for in-stent restenosis, we all know that vascular injury contributes to the restenotic process. There is an acute process, where you damage the endothelium, you end up with some form of platelet aggregation, thrombus formation, then you have an intermediate response, which is smooth muscle cell proliferation, and then you have extracellular matrix production, which is mostly a delayed response. Now, recoil and negative remodeling do not play a major role in the ISR. Stents don't allow that to happen. It's mostly a smooth muscle cell problem, that usually develop within the period of 3 to 6 months, and patients will be coming right back to you. When you look at clinical and angiographic risk factors, that includes diabetes, renal insufficiency, of course, the lesion length, as we just discussed, task D lesions, as well as pool runoff and the presence of calcification. There are some other possible mechanisms that would contribute to in-stent restenosis. We know very well that stent fracture, have been reported to correlate with some in-stent restenosis, particularly when it's advanced fractures. When you look at stent design and thickness, we've seen the differences, between the wall stent versus the nitinol stents. When you look at stent overlap, a lot of our restenosis would occur when you put those stents adjacent to each other or overlapping each other. And when you look at barotrauma with adjunctive angioplasty, how much pressure do you use after stenting? Is it 5 atmospheres versus 15 atmospheres? Does that make a difference? What about the thrombosis element that occurs with in-stent restenosis? 97% of patients who have total occlusion of their in-stent restenosis are not just smooth muscle cell. They are a combination of smooth muscle cell and a thrombotic process. So this is a difficult patient population to treat. What about slow flow in the distal vascular bed and small vessel size? How about those SFAs which are only 4 millimeters? They all make a big difference in the restenotic process. So again, restenosis after FEMPOP stenting is a progressive problem. It requires repeat revascularization. It's essentially the Achilles heel of femoral popliteal intervention, the same way as we have been dealing with coronary intervention prior to drug-eluting stents. And I can tell you it's pitiful right now to think about the peripheral vascular field, to be at least 10 years behind the coronary fields when it comes to research and it comes to our understanding to what happens in this vascular bed. There are several strategies, that can acutely treat the FEMPOP restenosis. Again, I'm going to show you a lot of data from very small studies, and that's what's so frustrating for all of us in this field. That there's really no large studies that has dealt with this problem. So you're going to see studies of 40 patients and 30 patients and 10 patients and 15 patients, which is very frustrating. But then these are the strategies that we tend to use. Of course, plain old balloon angioplasty remain a strategy, cutting balloon, atherectomy, cryoplasty, radiation treatment, drug-coated balloons, which we don't have yet in the US, restenting, like with bare metal stent or drug-eluting stents and covered stents. So let's look at plain old balloon angioplasty. I would say, when you look at this, you need to look at the pattern of restenosis to predict the outcome. And this is data that came from Tosaka and Jack in 2012, and what they did is they classified restenosis in 3 patterns. Class 1, when the lesion is less than 5 centimeter. Class 2, when it's more than 5 centimeter. These Class 1 and 2 does not include any occlusions. And if you look at Class 3, that's when you have total occlusion. And then, so when you look at the distribution of those patients, you find that 29% of the patients, are Class 1. Typically, that's what you see. Then 38% are Class 2, and about 1 in 3 patients are going to be Class 3. And so when you look, at the Kaplan-Meier distribution for the freedom, from in-stent restenosis, you can see that there is a sharp drop in that numbers down to almost the 20% at the 1 year and below 20% at 2 and 3 years in terms of freedom from revascularization. So very rapid loss that you see particularly in the patients who have total occlusions. And obviously this is not very good. And even in the class 1 and class 2, you still have freedom from ISR to be about 40%. So what about cutting balloons? Does cutting balloon do us any good? Cutting balloon does not do any good whatsoever in that situation, above and beyond what plain old balloon angioplasty does. And in fact, if you look at the data, randomized trial published, not too long ago in 2008, and you can see that there's really no difference, in terms of the binary restenosis rate between cutting balloon and plain old balloon angioplasty. And in fact, that illustrates how fast, this is 6-month data, at 6 months you have 60% of patients, returning back with in-stent restenosis. But how about cryoplasty? Look at this number of patients, 10 patients, 12 cryoplastic procedures. So dismal, it's really shameful even when we look at this data. We don't even have anything out there that would be solid enough, to present. But this is the conclusion based on 12 patients of the authors. Cryoplasty is of no value to patients with restenosis of the iliofemoral segment, with half the procedures failing within 6 months and all of them within the first year. Evidence to support the use of cryoplasty is lacking. What kind of evidence? 12 patients. All right, so what about radiation treatment? What about brachytherapy? Again, very disappointing. When you look at 79 patients, it's actually a subgroup of patients from a randomized trial that was published in 2005, and you look at POBA versus POBA and radiation treatment, no difference at all. In fact, the difference is so minimal, that, essentially we just dismiss that therapy for in-stent restenosis. How about different methods of treatment? What about atherectomy? Atherectomy is essentially removing the tissue, whether you do it by a directional atherectomy, whether you do it by ablative therapy. So let's talk about the Silverhawk atherectomy. Let me start by a disclaimer. The Silverhawk atherectomy is a contraindicated in the IFU to use inside a stent. If you look at the IFU, this is not an off-label, just off-label. This is a contraindication. And I use it. It's a contraindication. I use it because I can tell you what, that we've been using it for years before the contraindication was added to the label. It really has to do with the technique and how you use it. But let me show you some data that we've accumulated ourselves, as well other people have done with Silverhawk atherectomy. And this is before we talk about anything else about the clinical data. Let's talk about the intima media thickness that would appear following atherectomy. Is there any difference between POBA and the atherectomy device? And the answer is no. Again, as you can see, if anything, there is more growth of smooth muscle cell tissue and intima media thickness following atherectomy than just POBA. So that translates into very low patency rate. 25% is your patency rate at 12 months. In one study that was published in 2010, the lesion length was only 10.8 centimeter, which is really not bad, but the success rate acutely was very high. It was up to 97%. Now, we have had some better data from Zeller's group in Germany, where the 12-month data had 54% in terms of patency, and the 18-month data was about 48%. Not too bad, but it's still dismal if you look at the big picture of things. And again, their lesion length was about 13 centimeter. So that translates into a relatively higher target lesion revascularization. This is data from our lab, where we followed 40 patients. Procedural success was very high, but again, about 1 in 3 patients, at the end of 1 year that have to be revascularized. Looks better than plain old balloon angioplasty, but we have no comparative data between this and plain old balloon angioplasty. How about using laser for in-stent restenosis? Well, as you know, laser is an ablative therapy. The photoablation happens via multiple mechanisms. It's photochemical, photothermal, and photomechanical. And as you can tell, it works, acutely. This is a stent right there. You could probably barely see it. This is extending from the popliteal into an anterior tibialis. And you can see the laser is right there. And then you can see the treatment right after the laser. Looks pretty good. And following adjunct to balloon angioplasty, looks excellent. So acutely, it works very well. Then you look at the new data about the patent data that just got presented. In fact, I just realized this was published about 2 months ago in JEVT. And if you look at the data at 6 months, you look at patency, it was about 60%. And if you look at 12 months, it was 37.8%. Still a high loss, of the early initial gain that you get. And patency still very low. And in fact, if you look at the Kaplan-Meier survival curve, and this was updated in the papers up to 62%, TLR is pretty much in the range of about 40, probably 50% in those patients by the end of about 12 months. So again, you have to retreat those patients again and again. If you look at our own data with the laser, we had almost identical, a TLR rate, which was about 50% or so at the end of 1 year to the patent. Again, these are lesion length which were long, about 200 millimeter. Does it work acutely? Of course, 92.5% success rate acutely. But what's the problem? The problem is embolization. We had to use a high amount of filters in these patients, and despite that, we have about 20% embolization with the laser, pretty much what we've seen with the other atherectomy device. When we compare both the Silverhawk atherectomy and the laser, and this is a paper that just got published not too long ago, you can see that there is an initial rapid loss of patency and the need for TLR with the laser at 6 months. But then the Silverhawk atherectomy catches on, and by the end of 1 year, you can see that there is also a higher rate of TLR. And in fact, Silverhawk atherectomy tend to be a predictor of, TLR at the end of 1 year. In fact, statistically, there was no differences in the outcomes in this comparative study. Now, what about jet stream atherectomy? We just start using that in the ISR world. Again, it's an off-label application. And you can see this is an ISR. This is following jet stream atherectomy. Jet stream is essentially a device that cuts and aspirates at the same time. Excellent results acutely. This is following balloon angioplasty. You get very good results. In fact, we've adopted this method now in our lab for the ISR, and we're doing an investigator-initiated study compiling data in this. But I can tell you that there are embolization that would occur, and in fact, there has been the older generation, the pathway device, which preceded the jet stream, have had significant amount of embolization. When you look at patency, it's probably not very different from the others. This is 12-month, 33%, 24-month, 25%. Again, very dismal. Patency is low, no matter what you do. Embolization has been a major problem. This is a spider filter with large amount of debris, that you capture with the atherectomy. I tend to use filters in those patients almost on a routine basis. What about covered stents? The salvage trial showed clearly still a patency of about 48% at 1 year. So covered stents are not the answer. It falls kind of in the same ballpark of the others. This is same data with Gary Ansell's group. Again, the patency is 52%, also using the Viabond along with the PTA and laser. About the same patency data as we have seen with the others. So I don't think, we have a real answer at this point in time, except for some data that just start to appear with the Zilver PTX, which is a paclitaxel-coated stent, 3 microgram per millimeter square dose density. This is no randomized data at all, but if you look at this, this is the beginning of some encouraging results that we start to see with the ISRs. And if you look at the primary patency at 6 months, it was 95.7%. At 1 year, it's 78.8%. These lesions were about 13 centimeters in length. So I think with this non-randomized, at least prospective registry, using the drug-coated stents with the Zilver stent seem to offer some, at least compared to historic control, seems to offer some advantages. So what about drug-eluting balloons? Well, this is the 1 year data published in JACC just 2 years ago, or in 2012. You can see this was very high patency rate. In fact, it was almost up into the 90%. Again, the bailout stenting was 10.3%. Lesion length, however, were relatively short at 8.3 centimeter. But again, promising data with the biological modifiers, whether you put them on a stent or where you put them on a balloon. Again, this is the data from presented at TCT, 2012, 44 patients. You can see the primary patency was 90.5% at 1 year. So again, we don't have drug-coated balloons in the US, but hopefully in the near future we'll have them. But they seem to offer some promise in that. Again, what about after directional atherectomy using drug-eluting balloons? This is a retrospective study, 89 patients, and you can see this is a POBA versus atherectomy, with the drug-eluting balloons, and it's not randomized trial by any means, and you can see there is 84.7% patency versus 43% without the drug balloon. So I think there is clearly signals, that if we're putting the paclitaxel in these vessels, we are helping the in-stent restenosis process, whether you put it on a stent or whether you put it with a drug balloon. Again, no large randomized trials at this point in time for any systemic drugs. We know Platal maybe work. Some of the data from Japan, indicated that, but it's very small, of a small magnitude. Oral sirolimus, high toxicity. We do not use that. Photodynamic therapy is still highly experimental. I think there's a lot of good studies coming up. Drug-coated balloon versus laser. The PhotoPack, is data will hopefully be appearing this year. We have, the Excite trial, which is the POBA versus the laser, and several other studies, in the pipeline. But again, we're still a long way from finding a solution to this problem. Again, to summarize, FPISR remains a challenging problem. Acute procedural outcomes are really good. There's high rate of embolization with atherectomy. The use of filter is almost always indicated, especially in the long lesion and the total occlusions. There's promising new technologies with drug-eluting balloons and the drug-coated stents, so stay tuned for the future. Thank you very much.